very warm welcome to Katherine Kuzmeskas, CEO of SimplyVital Health.
Hello. As the CEO of SimplyVital Health, we are focused on allowing you to make the best healthcare decision faster. And we've talked a lot about data today. To be able to make a very good healthcare decision, data can help make that a lot more efficient. Anywhere around the world, we all know that healthcare data sits in silos. It's hard to access and it's not connected. You do need help, and that's where we can come in. So we focus on dislodging, refining, and distributing healthcare data so that you can make better decisions. Dislodging data is difficult. It takes time. Every data piece is different, and that's where having a partner in dislodging the data can be very helpful. Refining the data is just like it's just like oil. You hear data is the new oil. Data needs to be processed, cleaned, analyzed. A lot of data is unstructured. Some of it is structured. You need to connect it and relate it to one another. What we do is we push data through our platform and we create analytics out of that data. One key difference about us as a company has been a hot topic today is we as a company do not own your data. We do not own your data as the patient, and we do not own your data as a hospital or a physician or any healthcare participant in the system. This is really, really important, and it's an important conversation to have in healthcare right now. Any company that is looking to make a business model out of cleaning and refining data and selling that data back, it's not going to work any longer. We've talked about that today. We actually see data more as a renewable resource. Think of it like wind. It continually feeds our system. We continually use it, and we need a continuous stream of data. It doesn't make sense for us to hold and retain that data and then sell it. So instead, we facilitate the movement of data. We facilitate the refinery of data so that we can push it out of our systems and into the hands of patients and physicians. And we distribute it for consumption. For caregivers, we help them to identify variation so that they can make the best healthcare decision faster. We do very intentionally focus on physicians that are in what are called value-based care programs. In the United States, we are not rich in healthcare. We have to reduce cost, and we do that in a value-based care system. What that means is that physicians are reimbursed for value instead of volume. And actually what we do with the physicians is we communicate to them that value-based care is actually a strategic growth opportunity. It's a way for you to communicate to your patients that you're focused and dedicated to their overall care, not just the number of procedures and the number of times that they come to see you. Specifically, the program that we focus on, there's a target price. We help our physicians stay below that target price. There's a financial incentive involved in that. If they can keep the cost below that target price, they're financially incentivized. We've already talked about behavioral economics. Here in this program in value-based care, it's two-sided risk. You can gain, or on the other side, if it's over the target, you lose. This has created an incredible amount of focused change in our healthcare system. But you have to have data to be able to shift the needle and to make changes in that care. So what we do is we look at the data and we identify it in near real time according to the target price. As the patient comes in for their hip surgery, before they leave, how expensive was their hospital stay? How close are they trending towards that target? Once they discharge and they go to a nursing home, how long have they been at that nursing home? How high is your readmission? What % of your patients are going back by facility to the hospital? What's their infection rate? So everything we look at is narrowed down to identifying variability and reducing that variability, even down to the physician level. One of my favorite dashboards is what I wanted as a hospital administrator at Yale New Haven, and I couldn't find, which is why we created it. This is a scorecard where we can actually see every facility in a geographic area by quality rating. You can see red, yellow, green, also by cost, and the average length of stay. What our providers do is they use this to identify where they want to send their patients to a facility that is more focused on value over volume. So we have actually had conversations with the orthopedic physicians of a specific skilled nursing facility in New York City that is notorious for keeping patients for 31 days just because they can. So we're helping them shift care and have a really important conversation with the nursing home. The financial incentive for the nursing home is because they are also financially penalized for keeping a patient too long or for the patient being readmitted. So they want to see this data as well, and we share it with them. So we're looking at a whole ecosystem of data sharing. For patients, what we're releasing this Friday, I'm really excited about, is filtered, personalized information so that they can make a healthcare decision faster. This information may look familiar. It does already exist online in Google, but it's not very easy to maneuver through. It's in a lot of different locations. What we're doing is we're bringing it all together, and you can actually filter it and personalize it to you based on the physicians that are in your network if you connect it into your insurance. Lots of ratings and reviews. In the United States, we have ZocDoc, Vitals, HealthGrades, Medicare. We're bringing all that together so there's one unified view of the ratings of the physicians as well as quality metrics. They too have access to the scorecard so that when they're making decisions about their care as a patient or perhaps as a caregiver for someone else in their family, they now can look at cost, readmission rate, how well their patients will improve from mobility, and it just allows them to make a much more informed decision. So when you have access to data, you can make better decisions faster.
Thank you, Kat. So I was wondering, when you say you actually rate the hospitals or the physicians so that patients can make better decisions, why does everybody agree to giving you the data? I could imagine that a hospital who's got good numbers or is very successful would give you the data, but others would say,
Right.
I don't have to. Why would I?
Right. So this is an important conversation because in the United States, this data is actually required to be collected. So we had a conversation earlier. A lot of healthcare change in the United States is federally mandated. Healthcare is not unlike any other business. So any sort of consumer protection that we've seen in the food industry, banking, oil and gas was federally mandated. It's the same in healthcare. So all of the change that we're seeing from volume to value and then publicly available data sets was through federal mandate.
So you have the right to collect this data, and what about the patients? Do they sign their lives away with insurances so that you can access this data, or how do you get it?
So every time a patient goes in to see a physician, they sign a HIPAA release form. And the HIPAA release form, most patients don't know, actually allows the physician office, the hospital, to utilize their data in any way that they see fit, including selling their data. So this is also a conversation that they're having in the United States, is who owns and retains ownership of the data. Right now, there's only one state in the United States where the patient owns their data, and that's New Hampshire. And it's inconclusive in other states. Sometimes it's the hospital, sometimes it's the physician. So that's actually where we're making the blockchain play, where you can actually have an identity tagged to your data, and you can see who accesses it, when, and how, and you can track it over time, and you can give consent.
Who could use this blockchain technology? I mean, it's many angles have access to that. Who pays you for this? Who would say, who's the one? Is it the insurer, or is it that says, okay, we want you with your blockchains, come in because we know we do something for the patient, for everybody, accessible data. Who pays for it?
So think of blockchain as a piece of the technology stack. So the same way that an entrepreneur would use cloud technology and a certain coding language, AI, ML, blockchain is another part of the tech stack. So they're not paying for blockchain. It's more of a feature in the technology or a feature in the platform that is an additional asset. So that's what allows us to have a differentiating factor where we don't own your data. We don't want to own your data. Patient can own it. Hospital physician can own their data.
And I think a big part about it is also that the information in certain blocks can't be changed anymore. Right. So you get access to the whole story, and you can decide who has access to it. So you could say, no, I don't want the insurers to see what's been my history.
That's right. So one thing is you don't put healthcare information on the blockchain. One thing that we do what you just said is we govern access to data off-chain. So your consent is on-chain. So any physician could look at your consent on-chain and say, all right, I know that I can look at this piece of information and they'll connect it to the location where it sits. So it's very important to not put healthcare information on the chain because it is immutable, can't be deleted or changed. And so that's why you use it to govern access to wherever the data sits.
A system where patients pay for outcomes rather than procedures and doctors' visits. That's what I've read about that sometimes somewhere described as your dream. How would that work?
Yeah, so we're being very intentional in how we create these systems. So we're starting first with Medicare. So that's our public insurance system. And depending on which statistic and how you define value-based care, it's anywhere between 50 to 95% of reimbursement from Medicare is already value-based. So Medicare is already paying physicians based on outcomes. So for a hip replacement, did the patient recover? Were they readmitted? Did they get an infection? Did they have a blood clot? All of that affects their ratings and their financial reimbursement. What happens in the United States is you start with Medicare and then the private commercial insurers follow. But we're after Medicare, we're going after self-insured employers because if you think about this from a employee perspective, for an employer to be able to offer a value-based care health insurance system is very enticing. So this is what I did at Yale. It's my background. I understand value-based care very well. We started the market with Medicare. It's very easy, clean, packaged. And then we're heading into self-insured markets where we can bring it to more patients.
A lot of things ahead of you.
Yes.
Very exciting. Thank you so much for being here, Katherine.
Thank you.